dual and triple therapies with metformin and SGLT2 inhibitors and DPP4. So we know the efficacy of modern therapy with sulfonylurea. To deliver this talk, we are having an excellent orator, Dr. Shashank Joshi. I think he is known to all these, even then, in spite, I will introduce. Sir is the endocrinologist of Joshi Clinic, past chair, International Diabetes Forum, Southeast Asia, President, Indian Thyroid Society of 2023-24, past Dean, Indian College of Physicians, past President, APA, Emeritus Editor of JPEF, and past President of ESA and RSSDA, Founder Vice President of PCOS Society, and past Chair, India-American Association of Clinical Endocrinology and International College of Nutrition. So, to deliver the lecture, I am inviting sir and over to you. Okay.
So, thank you so much. Thank you, Dr. Jyoti Dev and his entire team and Gopika. So, this is a USV symposium, and I'm going to talk on a old wine in new bottle, which is maximizing efficacy of modern sulfonylureas and the role of this plain dual and triple therapies with metformin, SGLT2 and gliptins. So fundamentally, I want a show of hands from this room. Which of these therapies you choose most often when your A1C is not at goal after metformin? How many of you all give a gliptin-metformin combination? Show of hands. Okay. How many of you all give a metformin with SGLT2 inhibitor combination? Show of hands. Okay. How many of you all give a sulfonylurea like a glimepiride metformin combination? Show of hands. So again, I can see that probably still people use sulfonylureas compared to DPP4 or SGLT2 inhibitors. So as Professor Venkat Narayan said in his Kelly West lecture, that we are winning the battle and losing the war. As Indians, we are winning the battle and losing the war. Because we are thin fat Indians and we need to be treated differently. We are winning the battles because we are improving risk factors of diabetes and we are trying to reduce complications. So that is the victory. But those are battle victories. War is lost. Because our number one country in the world now has become India. And there is an explosion of diabetes. So we as a community, as Asian Indians, represent a very grossly understudied phenotype, where our beta cell secretion is poor and we need a more patient-centric approach. The data from our ICMR in-depth study, NIHS, IDF, all says that diabetes has exploded. And 50% of people with diabetes don't know that they have diabetes. But the biggest problem is at least 70% of people who are living with type 2 diabetes do not have an A1C below 7%, which means 2/3 of the population does not control their glucose yet. So clearly the unmet needs of type 2 diabetes in India is explosion of diabetes, a lot of complications, a lot of cost, and a failure to get to target. So that's the biggest problem. And our glycemic control is very poor, as I illustrated you. And traditionally we used single step, dual step, triple step, quadruple step, and we had to combine therapy quick and fast. So the first concept which I want to talk to all of you all today is hit hard, hit early in the first decade of a diabetic's life. Because in the first decade of a diabetic's life, we have created something called as a glycemic burden, and that drives that entire risk of complications. So in your first year of diagnosis of diabetes, if there is a poor A1C control, then there is a higher CV risk. There is a 67% higher chance of myocardial infarction, 51% higher chance of stroke, and 64% higher chance of heart failure. So whether it's stroke, heart failure, or MI, you clearly drive these complications, and finally, of course, cardiovascular events. So the Indian challenge is A1C around 9, uncontrolled diabetes, poor adherence, and of course hypoglycemia. And the 40 challenges as doctors we have is we don't have time, we don't have training, we don't have appropriate treatment modalities, and we don't have tools for operations. We are also seeing an explosion of prediabetes in the youth, in the young population, type 2 diabetes. And they all have microalbuminuria, blindness, and at least they live 15 years less. And we are seeing an explosion of micro and macrovascular complications. So clearly there is an underrated impact of diabetes. We know glucose drives sexual dysfunction. It affects overall well-being. It drives diabetic distress and impacts mental health and quality of life. And particularly in the young population, this is hitting hard. So clearly we recognize that poor glycemic control is linked to a lot of factors, including the sexual dysfunction. And glucose control matters. Clearly it matters. Intensive glucose control RCTs clearly matter, and we also have data that it does outperform on outcomes basis. The best data set on planet Earth we have is from UK PDS, 44 years, now of course 48 years. And clearly we recognize that hitting hard, hitting early creates a glycemic legacy. If you hit hard and get best glycemic control in the first year to the first 10 years, your intensive glucose control as early as possible will make a difference. Unfortunately, we go step by step. First step, insulin resistance. Second step, pre-diabetes. Third step, diabetes. Fourth step, complications. Fifth step, slow advanced diabetes complications. And unfortunately, we start with metformin, then add a SU or DPP4, then do a double drug, then do a triple drug. And if you really want to change this equation, you need to hit hard, hit early. Sulfonylureas have had a long history. Before First World War, more than from 1942, we saw the launch of laboratories. 56 after World War, we had tolbutamide, because you know sulfonamides were hypoglycemic antibiotics which were discovered in the World War II. And then of course you had UDGP trial on tolbutamide, which was nothing but insulin resistance causing heart attacks, but unfortunately SUs got a bad blame. Then we had a better SU. UK PDS had glibenclamide and chlorpropamide. Then we had gliclazide with advance. Then we had Carolina with glimepiride, Tossac IT, and then of course we had grade with glimepiride. Then we had Indian RCTs, and glimepiride has been there for quite some time now. Single drug, dual drug, triple drug. And clearly we see that SUs still are going strong. They are quick acting agents. They drop the A1C by 1.5 to 2%. So they are like insulin because they are secretagogues. They got rapid glucose control. They can synergize with metformin, gliptin or SGLT2 or even insulin. And they have very good durable outcomes, though they may have a challenge occasionally due to this. When we stop sulfonylureas, you can clearly see that it impacts control. And that data is available with us. And we can clearly see that if you want good glycemic legacy, do not withdraw SUs. Efficacy is well documented. Whether it's in monotherapy, whether it's in combination therapy, or whether it's with insulin, the drop of A1C is consistent. And therefore, SU solo is backed by good data in meta-analysis of lowering of A1C. We know that glimepiride has beneficial effects on CV risk factors. It blunts the cardiovascular risk. It's a randomized double-blind study in type 2 diabetic patients with glimepiride versus ripaglinide. And you can see the glycemic parameters very well affected. The monotherapy of glimepiride in a retrospective cohort of more than 1,95,000 patients has shown that it will decrease the risk of all-cause mortality. So in a population-based cohort, you can clearly see that there is some impact. SU-based combinations are still relevant. We have a lot of Indian real-world data which is published, whether you use a glimepiride metformin FDC, a DAPA glimepiride metformin FDC, you can see a lot of data, and some of the authors are like Rakesh are here, and you can clearly see that it matters. The good thing about SU-backed combinations is it delivers consistent A1C, and all of us use it even today. Despite of availability of new drugs, we still use it in a monotherapy, in a dual therapy, or in a triple therapy. And the lower dose of glimepiride has lower hypoglycemia risk, better tolerability, and very less lead gain. So in the modern era, we are looking at once a day or twice a day weight neutral, cost effective regimens which are insulin providing therapies. widely acceptable universal combinations, SU can be very safely combined or married to a metformin, a gliptin, a HL2, or even a glitazone, and even insulin or GLP-1 receptor agents. The synergy is best with the SU metformin, but it's equally compelling with an SGLT2 or a glitazone or a GLP-1. And clearly we recognize that safety, and therefore a modern low-dose SU combination, if properly appropriated and titrated, can even be used in high-risk or elderly population. The data is more than 40, 50, 60 years old, but lot of new data is also available. For example, this is a recent data in 2024 October, which combines a MET, SIT and GLIM combination. And clearly you can see here that glimepiride, when it is used, is cost-effective, weight neutral and effective second line. So when you look at the dual combination of glimepiride and metformin, again you can see it has a good benefit independent of age, diabetes duration, BMI, complication risk, or associated use with insulin and statin with a lower hypoglycemia risk. When we combine glimepiride, metformin and voglibose in the Indian program, again you can see that it has a reasonable impact, as well as a DAPA, glimepiride and metformin combination, which also has some robust evidence. And this is Sitamet and glimepiride FDC. So a lot of data which is available in these combinations. So you need to mix and match SU with MET, SU MET DAPA, SU MET Sita, SU MET Vogli. For newly diagnosed patients, maybe SU MET. For a person with high CV risk and obesity, SU MET DAPA. With a young patient with high A1C, SU MET Sita. With a high PPG, SU MET Vogli. So it could either be simple, potent, efficacious. It could be CV safety, weight neutral, or PP. So clearly, the take-home messages which I want to drive is that you need to hit hard, hit early. You need good, tight glycemic control in the first year or the first decade of a diabetic's life. And we have very, very good evidence, both from RCTs and real world, including Indian population, that glycemic control can be achieved. The modern SUs like glimepiride in the low dose also has very, very impactful A1C reductions, virtually like insulin. They're rapid acting, Provence energy. You can combine with MET, we can combine with gliptin, we can combine with the SGLT2 inhibitors, and therefore the low dose FDCs have high safety quotient. They can be very easily given with adherence. Compliance is good. You know, the combinations are very useful for compliance. They are cost effective and ease of use. And clearly we recognize that hypoglycemia weight gain can be mitigated, and even in high risk or elderly population can be dealt with. So clearly we can see that many of these triple drug combinations also, like a GLIM, MET or a DAPA or a SITA, can outperform dual therapy. So if your baseline A1C is 9% and above, maybe a triple between 7.5 and 8.5, maybe a double, and there's a lot of original real world data which is available from our country, which supports the use of sulfonylurea based combinations as a cost effective, well tolerated and a versatile combination. Thank you so much for a patient hearing.
So thank you for the excellent presentation. Thank you, sir.